Morning, Dr. Kaur. How are you?
Good, how are you?
Good, thanks for asking.
All right. So would you like me to start?
Yes, please.
All right. So I would be presenting a very particular type of neurodegenerative disease known as Friedreich Ataxia. And as most of us know, it's a hereditary condition which has an autosomal recessive pattern of inheritance, and it results from a mutation, more specifically from a trinucleotide repeat extension in a gene known as FXN, which codes for a mitochondrial protein called frataxin. Now, a mutation in this gene causes an impaired mitochondrial function, and all the organs that heavily depend on the mitochondria for normal functioning, which are the nervous system cells, organs, and the heart, they would be affected, as we would see shortly. Now, a bit about the epidemiology of the disease. It's not very common. It's seen on average in 1 per 40,000 people, and there is no ethnic or gender predilection in the disease. So, but it's like rarely found in sub-Saharan Africa and lower parts of the China and Japan, mostly seen in the Caucasian population. So the genetics of the disease are well known. It's a gene that's located on the long arm of chromosome number 9, and the mutation that happens is in the first intron. Normally, there is this GAA trinucleotide there that repeats itself around like up to 34 times. But in people who have Friedreich ataxia, it can repeat up to 1,700 times. So it's a like very long repeat in which the transcription, post-transcriptional modification of the mRNA gets damaged, and it results in lower levels of frataxin than normal. But in some rare cases, the mutation can also result from a missense mutation in the intron, so no trinucleotide repeat extension. It was shown in 1996 by Dürr et al. That, like in other conditions with trinucleotide repeat extension, same here, the more the number of repeats, the more severe the disease. This means that people who had a larger number of trinucleotide repeats, they had the disease usually set on at a younger age, and people died at a younger age as well. So there's like a direct correlation between the number of trinucleotide repeats and the severity of the disease. Same like in Huntington's and in other similar conditions. Well, a bit about the pathogenesis of the disease and how the disease develops. As I mentioned, it results in low levels of frataxin. It's important to point out that it's not absence of frataxin, it's low levels, because in murine models where frataxin is completely out, the mice couldn't develop embryonically. They would die shortly after implantation. So even a small level is required for normal development. But like normally, the frataxin is found in the mitochondria, and it's in close association with iron-sulfur complexes. So what it does, it binds to iron and it stabilizes the iron, making its antioxidant functions more pronounced, and it like neutralizes the oxygen there, reduces the oxygen, preventing the oxidative stress. So as we would expect with low frataxin, iron would escape from stabilization, and it would predispose the mitochondria to oxidative stress, to the production of reactive oxygen species, which can damage the mitochondrial membrane and would further lead to apoptosis of the cells. And as I mentioned, since this affects the mitochondria, it's not going to affect all the organs. It's only going to affect the organs that depend on the mitochondria for their normal life. That's the nervous system cells and the heart cells that really require the mitochondria. The other cells, the other organs, they can like live with a lower condition of frataxin. They can survive. It's not going to affect them so seriously. But the nervous system and the heart are really susceptible to this. And this model only like sorry, did anyone say something? Yeah, okay, so this is just the model of pathogenesis. This is a hypothesis. It's really hard to prove this scientifically, but there is evidence found in urine and in plasma showing high levels of oxidative stress markers, and most of the scientists and doctors agree with this model right now. I'm not going to go too detailed about the gross pathology of the condition. Later, if one of you guys has a question, I can show the pictures in the slides. I would just say that we have lesions in the spinal cord, in the dorsal root ganglion, which is responsible for the sensory and motor difficulties. We've got lesions in the cerebellum, which is responsible for the ataxia. We've got a very shrunken dentate nucleus here. And we've got problems with the heart. More specifically, that's a hypertrophic cardiomyopathy, concentric hypertrophic cardiomyopathy. And one thing that I didn't mention is that it was shown scientifically that mice without frataxin, like with low levels of frataxin, they wouldn't have any beta islet cells in their pancreas. Because for the proper development of beta islet cells, we require frataxin, and with low levels of frataxin, the islets wouldn't develop properly, so the people would be prone to having diabetes. All right. I want to focus more on the clinical and on the management parts of the condition. Now, the age of onset is early, relatively early, before 25, usually in the mid-teens, and it's a slowly progressive disease. It progresses on average in 10 years, but there were cases that it took more than 25 years for the disease to progress. And from the time of onset, from time of diagnosis to the time of wheelchair use, it can take up to 25 years. So it's not that fast at progression. And the death is on average at 37 years of age, and is mostly due to cardiac dysfunction. Around 2/3 of the cases are due to heart failure, and other cases are due to other conditions like diabetes or accidents due to the nervous system dysfunction. A typical patient looks like this. They have skeletal abnormalities. They are younger than 25. They're ataxic in all limbs. They have absent reflexes, and they have also motor signs, because the pyramidal tracts are also affected. And like everything that I mentioned is just the typical phenotype. It was demonstrated by Harding, Dürr, and Delatsky. 3 prominent studies showed that these are the main conditions, are the main symptoms of people with Friedreich ataxia. We can see that almost all of them had very strong neurological symptoms: ataxia, dysarthria, absent limb reflexes. We can see that skeletal abnormalities are also present in many people, scoliosis and pes cavus being the most prominent one. They even can present earlier than the neurological symptoms, so they can act as with a person with positive history, that they can show that people are prone to having Friedreich ataxia. We can have dysphagia and other vision disturbances, and most importantly, in around 2/3 of the patients, we can have cardiomyopathy, and in nearly 1/3 of the patient, we see diabetes. So again, this was the typical Friedreich ataxia, and it can also be manifest atypically. For example, the patient that we saw together had the late onset disease, a disease that happens after 25 years of age, and it's usually milder, and no cardiomyopathy, almost never cardiomyopathy. Same with another atypical phenotype called leg spasticity with little or no gait and limb ataxia. As the name suggests, there are almost no neurological severe symptoms and almost no cardiomyopathy. So these are really mild cases of just people who have the mutation, and they don't have so severe disease, such a severe disease. We can have Friedreich ataxia with retained reflexes, in which people have ataxia, but they have normal reflexes. They have their reflexes preserved. And in very rare cases, I just found a couple of case reports showing that Friedreich ataxia can also mimic Huntington with the choreiform movements. It can present as Huntington's disease. All right, the diagnosis is quite simple. It's clinical, and a genetic testing is required to demonstrate the trinucleotide repeat extension. But as again, in rare cases with no trinucleotide repeat, very small number of trinucleotide repeats, we can go with other tests to confirm the diagnosis, which are the MRI and additional tests like demonstration of frataxin levels. If we find a low level of frataxin, then we can pretty sure know that MRI we see quite a few things. We see a problem with the dentate nucleus. On the gray matter, we see on the functional MRI here, you can see lesions on the dentate nucleus, and we also see lesions on the white matter, so on the tracts rising from the nucleus, we also find lesions. But the cerebral atrophy in the condition, and actually absence of cerebral atrophy is something that supports the electrocardiographic ultrasonographically and echocardiographically, and an evidence of axonal neuropathy on nerve conduction studies can also support for the diagnosis of Friedreich ataxia. All right. About the differential diagnosis, again, I wouldn't go too detailed about this. I would just say that there are plenty of few conditions that are hereditary and that can present as Friedreich's ataxia, among which the most important one is ataxia-telangiectasia. And this condition differs from Friedreich's ataxia mostly because it has also immune deficiency problems. So people would have a lot of like pulmonary infections, recurrent pulmonary infections. It's easy to differentiate. And about the others, I can mention them if you have questions, but these are all like hereditary problems, ataxic problems, and they also run in the family and can present as Friedreich ataxia. The management of the disease is quite challenging because there are no ways to modify the disease. There are no like medications that help us prevent the progression. So the therapy mostly relies on symptomatic treatment. We can go to physical or occupational therapy. We can manage the heart if the heart starts failing. We can manage the arrhythmias. We can treat the diabetes, do diabetes screenings, do speech therapy, urodynamic therapies, sleep studies. So we can manage all the symptoms, but we can never prevent the disease from progression. Anyways, like the good thing about this is that there are really promising medications that are currently undergoing clinical trials, and it's like hopefully they would show efficiency as disease-modifying agents. Right now, most of the studies were focusing on drugs that were against the oxidative stress, oxidative damage. So basically antioxidants, including the over-counter antioxidants like vitamin E or coenzyme Q, or the drugs mentioned here like idebenone or AP743. These are all drugs that are preventing oxidative damage, but none of them was found to be more effective than placebo in clinical trials. So they're not recommended, they're not prescribed usually. But what I want to focus on is the drugs that are thought to modify the disease. Drugs that are thought to increase the level of the protein that is missing in the condition. Erythropoietin, a drug transactivator of transcription FXN, and interferon gamma are all currently being studied. They have side effects, but they are like very good candidates of future treatment. This TAT-FXN drug is actually a very expensive drug that is like, it's the protein with a small marker on it, and it's being injected into the cells, and it travels into the mitochondria and like resides in the mitochondria, increasing the level of frataxin, so possibly modifying the symptoms that result from the absence of the frataxin. And two very like recent medications, inhibitors of histone deacetylase and nicotinamide. These are two drugs that work on the genes, work on the gene of frataxin, and possibly revert the silencing of the gene. So they're trying to like modify the silencing and increase indirectly the levels of frataxin. These are all being studied. These are all like these inhibitors of histone deacetylase are in the phase 2 clinical trials right now, and they've done very good so far, and they're like most likely gonna be used as the treatment of the condition soon. And I want to focus on the gene therapy as well, because I also consider this to be the future of the condition. And as like in all other cases with gene therapy here as well, we've got like viruses that have the gene that is missing or mutated, and we inject the viruses and they deliver the gene into the nucleus. The problem with this is that we have to use herpes, not adenovirus. We have to use herpes simplex virus, which have more affinity to the nervous system cells. And we have to use, like, since many cells are affected, we have to use a lot of vectors, a lot of virus, and that can create problems, very like significant side effects, and we want to prevent that. So a lot of research is being done currently on the gene therapy for Friedreich ataxia to possibly find ways to incorporate this into the treatment. So far, this was it about the disease. And if you have any further questions, I would love to answer. And here are the references. If anyone is interested, I can send them.